Great. Good morning or good afternoon, wherever you are. Welcome to Diabetes Care in the Age of COVID-19, the growing role of telehealth and diabetes specialty clinics. This is brought to you by the Leona M. and Harry B. Helmsley Charitable Trust and by Cecilia Health. I'm Amy Tendrich. I am a patient advocate and a journalist, and I started one of the very first information resources by and for people with diabetes called Diabetes Mind, which is now part of Healthline Media in San Francisco, where I also serve as editorial director of patient advocacy. So I live with type 1 myself, and I've been involved in numerous advocacy efforts over the years. I'm currently an active advisor to the ADCES, which of course is the new name for the American Association of Diabetes Educators. And I also run a series of innovation forums around diabetes technology, the annual Diabetes Mind Innovation Summit, and our biannual Diabetes Mind D-Data Exchange event. So I am delighted to be here to be hosting on this important topic. Before we get started, a couple of housekeeping items. All attendees, of course, are going to be muted for the entire webinar. We do encourage you to ask questions during the webinar. In order to do that, use the questions section of your dashboard that you'll see, and we'll answer as many questions as possible, of course, during the Q&A portion at the end of the program. You can also ask anonymously if you prefer. And if we don't get to your question during the live discussion, no worries, we will respond via email afterwards. And the recording of this webinar will also be made available to all attendees starting tomorrow, July 15th, via email and also on the Cecilia Health website. So to dive in, diabetes clinics, of course, are chronically overwhelmed by their patient load. And meanwhile, few people with diabetes have access to specialty care due to where they live. They're simply too far away to get to the nearest endocrinologist or the nearest clinic. And of course, COVID-19 has added a whole nother layer of complexity to this. But telehealth and virtual care have a tremendous opportunity to help. So the two organizations supporting today's program are actively working on this. Nationwide, there are over 50 universities and hospitals that are receiving support from the Helmsley Charitable Trust for their diabetes clinics to help them manage through the COVID-19 crisis. And Helmsley has also contracted with Cecilia Health to provide those clinics with extra bandwidth as they shift to telehealth. And they can take advantage of Cecilia's expertise in helping people manage insulin-dependent diabetes and ease the daily burden of living with the condition and improve their outcomes, of course. So this webinar, we're going to take a look at how clinics have pivoted to telehealth models and a vision for the future of specialty care. So we're going to be talking about access, affordability, and patient experience. Starting with the current and future state of diabetes care, we're going to be talking about the rapidly growing diabetes population and how expensive they are to treat, the disproportionately low and shrinking number of endocrinologists, limited rural access to in-person care, and working to scale the model for high-quality, low-cost diabetes and mental health care, and then proving and implementing that model. And then we'll end, of course, with the Q&A. So I'd like to start off our conversation here with directing a question to David Panzier. Oh, first of all, let me introduce, of course, our panelists. David Panzier is a trustee of the Leona M. and Harry B. Helmsley Charitable Trust, and he is the grandson of Leona Helmsley. He is closely involved with their type 1 diabetes program, which he helped to launch in 2008, which seeks to improve care and ultimately prevent the disease by working closely with key players in the type 1 ecosystem. And David's daughter also has type 1 diabetes and recently published a book. We actually published a review of that book yesterday on Diabetes Mind, so with a giveaway. So if anyone's interested, you can go check that out. We have with us also Dr. Ruth Weinstock. She is a SUNY Distinguished Service Professor and Division Chief of Endocrinology, Diabetes and Metabolism at the Department of Medicine at SUNY Upstate Medical University in Syracuse, New York. She's also the Medical Director of the Clinical Research Unit and Medical Director of the Joslin Diabetes Center at Upstate Medical University. And over the past 30 years, her research has focused on the study of new approaches to prevention and management of diabetes and its complications. We also have Dr. Susan Bean, who joined Health First over 10 years ago, and she is currently VP and Executive Medical Director of that group. She focuses on care management and clinical provider partnerships, and the programs are especially designed to improve the delivery of vital evidence-based healthcare to Health First members. So Dr. Bean has served as Chief Medical Officer for Affinity Health Plan for 5 years previously, in which time she helped that plan become a top performer in quality and member satisfaction. And last but not least, we have David Weingard, who is, of course, a visionary entrepreneur who's dedicated his life to making a difference in the lives of people with diabetes. David left Microsoft following his own diagnosis with type 1 diabetes to start Cecilia Health, which is a technology-enabled personalized coaching company that is focused on empowering people with chronic illnesses to live healthy lives. So welcome to all the panelists. As you can see, we have perspectives here from the payer side, industry, from nonprofit, and from clinical, so an incredible mix. And again, now I'd like to start by directing a question to David Panzier. David, how would you describe the current state of diabetes and related mental health care in America, and what has been the impact of COVID-19?
So thank you, Amy, and thanks for the shout out for my daughter's book. Very much appreciated. I also have a second daughter who was diagnosed 3 years ago. So I've got 2 of my 3 children have type 1 diabetes. But I would say the state of diabetes in a nutshell is horrible in the United States. We know with type 1 diabetes, less than 30% of people hit their recommended ADA targets. And we know with type 2 diabetes, the epidemic has not slowed down one iota. As a matter of fact, it's still on a hockey stick curve up. And just real briefly, because there's often a lot of confusion, the differences between type 1 and type 2 are pretty stark, although they get lumped in all together. Type 1 is an autoimmune disease where your body attacks and kills its own insulin-producing cells. Insulin is a hormone that your body needs to metabolize carbohydrates. Without it, you die, period, full stop. Type 2, the majority of people can be treated with lifestyle and diet adjustments, etc. But here, and just make the distinction because it's very, very important. In the United States, we treat symptoms and we do so as cheaply as possible. We don't take care of the whole person. And despite spending almost double per capita on healthcare than most other developed countries, our outcomes are mediocre at best. And when you think about what the issues are, the problem really is, from my point of view anyway, is the payer's perspective is only 2 to 3 years out. And the reason why is that people shift insurance companies every 2 to 3 years. So a payer thinks, your long-term issues, especially with diabetes, are going to be somebody else's problem down the road. And you get this revolving door that ends up happening. Then when you layer in, we all talk about patient centricity and they're great buzzwords, but in reality, that's all they are. They don't happen here in the US. We don't put the patient center, because if we did, there is no way that you would not look at the statistics, which are quite clear. With chronic disease, there's a comorbidity of a mental health condition at least 40% of the time. And like everything in mental health, we're sure that's grossly underreported. So when you look at type 2 diabetes, just as an example, right, we have had diet apps, we've had nutrition apps, we've had exercise apps for over a decade. And the problem, in my opinion, is that we don't solve the underlying problem. All of these apps are the equivalent of a fad diet, right? You get a little bit of near-term win, but you don't actually solve the underlying issue. So with type 2s, which is a very tough disease to be compliant with, but what you don't solve is the underlying depression, anxiety, or empowering the patients. And the truth is, to go back to the diet analogy, the only thing that works with a diet is a lifestyle change. I would argue mental health and treating people with the mental health condition is the equivalent of getting the lifestyle change. There is no health without mental health. It's extremely logical. Yet here it's very stigmatized. And I feel like it's also generational, right? So my generation, you would never ever talk about mental health. And today I feel like the kids wear it as a badge of honor to talk about, they're in therapy or they're this and they're that. And here's a statistic that I've heard from Michael Milken, and that is 100% of us will have a mental health issue during our lifetime. We need to stop taking shortcuts, start acknowledging it, and treating it front and center, right? In diabetes, rarely do we get mental health. And we were talking about this a little bit before we came on. When you get diagnosed with cancer, you are automatically put into some sort of mental health program where you see a mental health professional. That rarely happens in diabetes. Yet I would argue it's as grueling, if not more of a grueling disease, because you never get a break. And I'm not trying to equate diabetes and cancer. It's very different, I recognize. So thankfully, some of the payers, I'm going to wrap up, Amy, I promise. Thankfully, some of the payers are starting to realize that mental health is really the wave of the future, and that we have to start treating the entire person and not just trying to treat the symptoms. And to just wrap up, what we have seen with COVID, the shifts that have happened because of COVID has really given us an opportunity. Shifts that would have taken years have now happened in weeks. And shame on us if we ever go back.
Okay, good. Let me ask you very quickly to follow up on that. So do you mean just simply that it's pushed us towards more virtual care, or is there more to it than that?
Yeah, so certainly more virtual care. I mean, Dr. Weinstock can talk and Dr. Bean can talk about how that's reimbursed, but prior to COVID, there was very unequal reimbursement for telehealth. It was really hard to get reimbursement. I think now it is, at least temporarily, generally widely accepted and is the new norm for almost all of the clinics.
Right. Okay, well, let me direct a question then to Dr. Weinstock. Let's talk about care delivery challenges that diabetes specialty clinics and their patients face. And of course, how have these issues been exposed during the COVID-19 pandemic?
Yeah, thank you. Well, from the day we opened our diabetes center back in 1995, we have been overwhelmed with people with diabetes who wanted to be seen. Pre-COVID, we were receiving over 100 new patient consultation requests a week. These are people coming from over 20, primarily rural counties and all walks of life, including many, many who live in poverty, going up all the way to the Canadian border, and some patients who have to travel 4 more hours to get to our site. Also pre-COVID, we were receiving about 8,000 phone calls a month, as well as numerous electronic messages through portals. And on top of all this, the management of diabetes really has become much more complex with increasing use of new and rapidly changing technologies and devices and availability of more medications. And these developments really have the potential to greatly reduce complications and improve quality of life. But they require significant time to tell patients about them, time to teach patients how to properly use them and benefit from them. So pre-COVID, meeting the needs of people with diabetes in our region has always been our biggest challenge, and we acknowledge that many needs were just not being met. And in addition to our limitations of physical space and staffing, many of our patients with the greatest needs have the greatest difficulty coming to face-to-face visits. Problem taking time off from work, transportation problems, problems related to other comorbidities, disabilities, mental health issues, financial limitations, and all these things hamper our ability to help them meet their needs and get to their goals. And in addition, our inpatient visits were inefficient, due in part to the time and effort to download all their devices. I'm talking about the glucose meters, the continuous glucose monitors, the pumps. And although the majority of our patients would have benefited from receiving more self-management education and training, honestly, we didn't have the staff to do this for everybody who needed it. So now COVID-19 comes, and that has just exacerbated all these problems. Overnight, we had a change from face-to-face to remote visits. We would have loved to have been doing telemedicine before this, but it was not reimbursed for most of our patients. And we didn't have enough staff to prepare our patients to do the televisits or to meet their education needs. So now, even now, we can see a limited number of our patients at our center, but rooming takes even longer with the need to screen for COVID, physically distance, take other precautions. And we need to definitely continue to use telemedicine. I mean, we just can't return to our pre-COVID patient volume safely in our current very constrained physical space. So our ability to temporarily use remote diabetes educators from Cecilia Health, thanks to a grant from the Helmsley Charitable Trust, was the most precious gift, really. I mean, these educators were able to remotely help our patients in many critical ways. First, they help prepare for the provider televisits, including teaching them how to upload the glucose and insulin data from their devices. And this is really key because this gave us the data that we needed at the time of the visit so we could actually make changes in our medical regimen, understand what was going on, and better help the patients. And in addition to that, there was a huge silver lining to this, in that these remote diabetes educators, who are really wonderful, they really help fill in other education gaps related to lifestyle issues, proper use of devices, are people injecting correctly, are there needs for social services, identifying barriers for reaching goals, including mental health issues, address safety issues. So for our patients with type 1 diabetes, do they have glucagon at home? Do they have ketone strips at home? Do they remember how to use them? Do they understand sick day rules? Provide general emotional support, and also to start some of our patients on the use of CGM, which does take training. Many patients cannot do this on their own, and help identify glucose trends and patterns and make insulin and dietary adjustments. So since starting to work with Cecilia Health, we've referred, I believe, close to 1,000 patients now, the vast majority who were able to connect and were able to benefit from this. So it's really clear to me that remote visits with educators and providers working as a team can really be effective and much more efficient, and really can give us the potential to help many more people with diabetes achieve their goals. And of course, that would reduce morbidity and mortality.
That's really powerful. I have a quick follow-up question. So the one thing that seems to be missing from the equation, what about lab work? Are you using home A1C kits or?
So, so that's a very interesting question. So in terms of A1Cs, honestly, if someone is using CGM and I can look at the GMI, the glucose management indicator, I go by what the glucose values are. There actually are a lot of limitations with A1C. You can have an A1C at goal and having a lot of hypo and hyperglycemia, or you can have an A1C at goal and you're just where you want to be. So if someone really has a CGM device and they are downloading that, that to me is much more important than getting an A1C. And yes, some people we have to send to labs for their renal and lipids, and there are especially some of our patients with complications. But our lab, we can accommodate people in our lab as a quick in and out and socially distance for people who absolutely need to come in for a lab. But actually doing full visits, we just don't have enough exam rooms, enough ways to socially distance, enough staff to clean the rooms between each patient. I mean, there's just a lot involved.
Got it. Thank you. So I'd like to direct the conversation to Dr. Bean now. From the payer perspective, how has COVID-19 changed how your organization thinks about supporting its members with diabetes?
Well, there's no question, just as Dr. Weinstock and David mentioned, that we are having to understand this new blended way that healthcare will be delivered forevermore, which is that there will be face-to-face visits, but there will be many, many, many visits that happen via telephone or via technology and other ways of communication. And I think that that's an important lesson for us, to David's point about payers, and also Dr. Weinstock, we are held to certain standards, metrics, if you will. I'll just use as an example, A1C is a metric that we are, held to in terms of, how are your members doing with their A1C levels. One of the ways that we actually began working with Cecilia Health is really an interesting story. We've been on a long journey with Cecilia Health to understand our membership better. And Cecilia Health is a provider for us. I don't even consider them a vendor. And what we learned is that early on that we could impact A1C with Cecilia Health, and we showed that twice. So that's just truth. Lower A1C in a statistically significant way, but just lowering A1C didn't actually change the trajectory of health for our members, quality of life, et cetera. So a person living with diabetes, I'm actually pre-diabetic, and I can tell you that I'm a fanatic about it because obviously I didn't want to become diabetic. It's in my family and I'm one of those normal BMI pre-diabetics. So what I've learned personally and my team at Health First has really begun to understand from the member perspective, the community perspective, is that living with diabetes is not just a blood value. It's all about diabetes impacts you from head to toe. And I think that we've reached a plateau in outcomes in terms of how we help people, both type 1, type 2, and the combination. You know, if we don't address the science that really points us to looking at whole people, and as diabetes, you know, being a process that impacts a whole person. So I would say the future, if I were to say where payers who are going to be successful going forward in managing and co-managing with our members who are living with diabetes, you know, great outcomes, we will be thinking about, you know, depression, anxiety, and stress, right? We will be thinking about every kind of comorbidity that we might be able to avoid. And that means more than just A1C management. We will think about supporting people whose lives have been turned upside down with diabetes and have to change their diet and have to change exercise and have to change how they even interact socially. So yeah, I think that payers are having to, in conclusion, look at this this condition as an opportunity to understand root cause from the evidence, but also understand how conditions like this impact the membership that choose us as their health plan.
Well, that
Oh, I didn't speak to COVID. Can you give me one more second to speak to COVID?
Sure.
So COVID doubled down on this because Health First serves some of the most vulnerable people in the New York City region. We mainly cover Medicaid managed care, Medicare Advantage, and the exchange, as well as some commercial products. So our members really not only experienced the challenge of not reaching their physicians and their healthcare, many of our members and people living in New York City and beyond are food insecure. So if you're food insecure, how in the world are you going to manage your diabetes? So COVID-19 has really elucidated for us what happens if we don't support a resilient lifestyle, you know, for people living with diabetes.
Well, thank you for all of that. What I wanted to say is, like, that's all music to my ears, because it really does away with this notion of the non-compliant patient who's just being naughty and what they're supposed to. Really recognizing all those life challenges that get in the way. So thank you for that. So let's turn to David Weingart for a moment. Obviously with Cecilia Health, what have you learned about virtual diabetes care that enabled Cecilia to respond to the challenges of COVID-19?
Well, the way we responded was really building on the lessons we've learned over the last decade. You know, first of all, diabetes is hard. You know, building on Dr. Bean's comment, you know, head to toe, people are very overwhelmed when they're diagnosed, and it's a 24/7 condition. So they're continually feeling a sense of failure, and they need to be supported and educated and given compassion so that they could live an empowered life with diabetes. And that's what we've been figuring out how to do for the last 10 years, innovating use of technology so that it becomes scalable. We're not only helping, you know, a dozen people, we're helping hundreds of thousands, millions of people. And so, you know, the other problem that we saw prior to COVID is half the people that are prescribed a diabetes medication drop off in the first 6 months. And so getting people to initiate their medication and be persistent on their medication or use the device is also critical to their health and their ongoing care. And so when COVID came, we were able to rapidly take these capabilities and pivot to help the clinics directly, thanks again, as Dr. Weinstock mentioned, to the Helmsley Charitable Trust, and provide the outsourced capability where people are not going to visit the doctors. The doctors want the patients to follow their care plan. Well, how does that work? And they really need a personalized, trusted engagement with a diabetes educator, a clinician who's a nurse, a dietitian, a pharmacist that really understands the complexities of diabetes that we've been talking about. And in addition, really understands the diabetes tech, because these new devices that are coming out, we've used the term CGM, it stands for continuous glucose monitor. The leaders in the market today are Abbott and Dexcom. You can get them through pharmacies or through your insurer. But getting people to try it is different than getting people to try it and stay on the device. And when you stop having to test your blood sugar and you get real-time data to what's happening throughout your day based on the food you eat or the exercise, or, you know, if you have a cold, you know, you really are able to adapt and self-manage your condition. And so we've been working on not only getting patients initiated and persistent, but getting them to be able to interpret the data on their own so that they see the interactions and they can take care of their condition. It also really makes for a much more efficient provider visit, because if we could, what we've learned is that most of the patients, in fact, over 85%, were going to the clinic to download the data to their provider. Well, the reality is the data is all cloud-based. So why can't they do that at home and use the valuable time with the provider for the live engagement around, you know, how to optimize their diabetes or change medications or take the conversation to an advanced level. So for us, getting patients on the devices, persistent, using the data, not only help the patients, but also help deliver efficiency and value-based care for the provider and the endocrinologist who are caring for the patients.
All right, thank you, David. Good, so in that round, we kind of talk about where we are and what we've learned, and now let's shift a little bit to where we need to go. So I'm going to ask you all a little bit about your vision, starting with you, David Panzier. We talked about the need for high-quality, affordable diabetes-related mental health care. What is your vision for sort of getting us there?
Yeah, so if you think about it, right now geography dictates your outcome. It dictates your ability to see a doctor like Ruth, a specialist. It dictates access to, since most continuous glucose monitors and most insulin pumps are prescribed by the specialty clinics. If you're not going to see a specialist, you're not getting prescribed a CGM or an insulin pump. And almost anybody in the diabetes space who's taking insulin will tell you that the most important tool is a continuous glucose monitor. So if you're not seeing a doctor like Ruth, you're not getting a CGM, period. So think about that. Where you live dictates whether you have access to specialists and specialty care. In today's day and age, the technology clearly exists to change all of that. Right now, we're doing it, right? Because people are no longer going into the clinic and seeing the doctor. So we had this vision 3 years ago. We met up with Cecilia Health. David and his board were completely aligned with our vision. And that vision really is very simple, that everybody should have equal access to quality of care regardless of where you live, and should be able to see the specialist. And with all due respect to Dr. Weinstock and all the doctors out there, everybody knows in the diabetes clinics, the heavy lifting is done by the certified diabetes educator. So, you know, David's model of the certified diabetes educator being the key and being front and center really was aligned with our vision. So what we did and what we have done to date is we did a small pilot where we remotely onboarded about 35 people to continuous glucose monitoring. We supported them for 90 days using David and his team as the virtual specialty clinic, because that's what we've been calling it. Long story short, it was a very easy success. All 35 people used it throughout. All 35 people had significant drops in A1C. All 35 people had wonderful patient-reported outcomes and felt more confident about dealing with their disease after learning how to use, both David and Dr. Weinstock spoke about, understanding and interpreting the data for CGM. So when you think about it, where we're going now is we're doing a much larger study of about 300 or 400 people. And again, we're going to be using Cecilia Health. The difference between that, the first study and the second one is I took the protocol that we wrote with Dr. Weinstock and a number of other experts, and we went to two payers, two very large national payers. And I said, I don't want your money. I don't want anything. I just want your folks who make decision-making decisions on whether to cover or not to read the protocol. Tell us what we're missing. Tell us what other data you would like. One of the payers loved the idea so much that they said, not only do we want to get involved, we want you to recruit out of our payer population. And if you give us some money for some of our analysts, we'll help you do the data analytics ourselves, because we don't really see the value of CGM, yet we cover it. So they really truly believe that layering in mental health, and mental health will be layered in front and center. Everybody will be screened. Everything that you can deal with in Dr. Weinstock's clinic as far as mental health will be dealt with by Cecilia and the team. Anybody who ticks a box for something more serious will be given a warm transfer to a psychiatrist or whatever is needed. And when you think about what we're doing and what COVID has done, is COVID has really given us an on-ramp to where we were going anyway. And you think about the future, it's an absolute no-brainer for rural America where people cannot travel the distances to see the specialist to use this model. And quite frankly, it's a model for the future, even in urban areas. We've had many people tell us that, even in the urban areas, they don't need to see everybody 4 times a year or 3 times a year. So telemedicine has the ability to level the playing field and is already doing it right before our eyes. And as I said earlier, I hate to say it, but I've heard this expression, we shouldn't let a good pandemic go to waste. Now is the opportunity to seize on what is changing before us for the better in the midst of all of this craziness. And as I said earlier, shame on us if we don't seize this.
Thank you. So David Weingart, ask you to expand on that in terms of how Cecilia helped.
I'm going to interrupt our moderator and speak directly to David.
Okay.
Pence. Health First is sitting right in the midst of a serious gap in terms of services available to the populations that we serve. Our members will report that continuity of care is the most important thing to them, and they definitely love Cecilia Health. So I'm wondering why Health First wouldn't be a good partner potentially for you to test what you're saying in a place where geography absolutely dictates outcomes, the New York City region. I'm just throwing that out there, Amy. I apologize.
We can talk about that offline, but this cake is baked. We're recruiting probably next month.
Yeah, but I mean, it could just be a conversation, because I'm feeling like we know in our region that this kind of thought process is really, really critical. So I just encourage the two Davids and maybe Dr. Weinstock after this call is let's chat and see what we can do in our region. Sorry, Amy, go back to you.
Not at all. I just wanted to ask David to jump in a little bit and talk about Cecilia Health, how you are executing against this vision, obviously, of improved care. You're in a unique position working with pharma, med device companies, health plans, and providers, and of course, patients directly. So tell us a little bit about your vision.
Absolutely. So one comment first for Dr. Bean to illustrate her point that one thing that's really important part of the patient engagement is speaking to people in their own language, in their taking into account their socioeconomic profiles. And in New York, where 28% of the Hispanic population have diabetes and 33% of the African American, in Spanish you have to speak Dominican Spanish, the foods that need to be eaten. It's very, very specific, and that's one of the lessons that we learned that we'll bring into the vision of the clinic itself. What's interesting about the clinic, especially you leveraging all the technology that we've been talking about, is so far to date, over the last decade, we've engaged in this scalable model with the patient through the diabetes educator directly to the patient and helping them to self-manage in all the ways we've been talking about: lifestyle, education, nutrition, etc. Well, let's look at the big picture. There's 32 million people with diabetes in the US. And guess what? By the year 2030, 1 in 3 Americans will have diabetes. At the same time, we have this growing population of people we need to help. We have a shrinking population of endocrinologists. There's only about 3,000 or 4,000 endocrinologists for the whole country. And most of them are located on the East and West Coast. So what do you do if you need help and you need medication adjustments? Even here in New York City, where I have great access, I still have to wait 3 months for my endocrinology appointment. So imagine what somebody in the Midwest, where there's 2 endocrinologists in the state, how are they going to get care? So what we've done is we've taken the core of the one-on-one personalized engagement, and we've layered on the technology that's available, decision support algorithms that take in data at scale from continuous glucose monitors and make recommendations of dosing and titration adjustments. and we've set up a legal infrastructure that now we have a nationwide network of licensed endocrinologists where we can engage the whole patient. And so now, our diabetes educators, when they're working with the patients and they notice that there should be adjustments made to the medication to help the patients manage, in our current model, we'd have to guide them back to their provider, which may or may not happen. So we're not closing the loop fully. And especially in today's world, there's a high probability that it's not happening. But now we'll be able to actually make the adjustments because we're set up as a legal provider across the country. And this is a phenomenal innovation, and it's a phenomenal way to solve for the huge tsunami of patients that are coming our way with diabetes. Imagine also a use case where you have a child with diabetes, and then they have a great care team. The family moves to another state. They have to start from scratch. What happens when the child goes to college? Start again. They go to camp. They get married. They move to another spot. Imagine virtual care where there's people who trust, there's trust developed between the patient and the care team. They know what's happening, and people can get support from wherever they are at the time they need it, after work, when they have privacy at home, and not during the day when they're at the employer, or maybe when the kids are in bed or a spouse is home to help. That's what we need to be able to do. And right now, the telehealth environment during COVID has reinforced the critical need for not only doing the patient engagement in a behavioral way, but in a medical manner. And that's what we're rolling out actually in 2 weeks.
Thank you. Actually, it's interesting because I think about the first 10 years probably of my work at Diabetes Mind, one of the most common questions we got was, oh, I'm moving to this state or that city. Do you know an endocrinologist? People were just desperately looking for recommendations, and we barely ever had any. So thank you for that. So Dr. Weinstock, for an established clinic like Joslin, I guess the question is, from what you learned from this COVID situation, are there new best practices that are emerging? What are you seeing as the optimal way to deliver quality care through the Joslin Clinic?
Thank you. And just before I answer that, I just want to say to David that I totally agree with what you said. And I totally endorse the central role of diabetes educators. And as medical director, our challenge has always been paying for them, covering the salaries, because of the very poor reimbursement for their services. So it's a loss. So that's been our biggest challenge. But anyway, to answer your question, I truly believe our care model has to change and should change. And it should include a combination of remote and in-person visits tailored to the individual's needs. I think that would be optimal. One size does not fit all. On one end of the spectrum, we have adults who have lived with diabetes for many, many years. They're at their goal. They require way less frequent visits, less frequent than every 3 months, maybe even less frequent than every 6 months. But to be able to have additional visits when a problem arises or when a new medication becomes available or a new device or a new technology, so that they could be trained in that or it could be discussed. But on the other side, we have lots of people with diabetes, unfortunately, who have not reached their goals, and they really do need more frequent visits. They may have more challenges related to all the issues that have already been discussed, and then they need more frequent visits. So maybe every 3 months with a medical provider, but in between, diabetes educator visits, mental health professionals when needed, social worker or social services when needed. It has to be tailored to the individual's needs. And I think that when we do that, then we could better meet goals. So it shouldn't be one, we should use a multidisciplinary team approach. We definitely should continue to use telemedicine. It's very efficient. We find it's our patients who live in inner city Syracuse have just as many barriers as our patients who live in the Adirondacks, several hours away. So they may be slightly different barriers, but there are definitely barriers. So we need to be able to address all those. We need to be able to use remote and in-person when needed. And that should be part of our future diabetes care model. Our visits as providers from people who have been well prepared, who have uploaded their data ahead of time, are much more efficient. I think they're much more effective. And I think that potentially in the future, we could see more patients. We could help more patients. with all this, ancillary support. And certainly our patients' comments for people who have interacted with the remote diabetes education, most of them have expressed a lot of gratitude, and they were overwhelmingly positive. Even people who've had diabetes for a long time, they had new insights, they received helpful suggestions. And again, the technology and the devices, things are moving so rapidly that even people who think they know and think they're doing fine, there are always new things. And I think almost everybody with diabetes could use refresher and, help with optimizing their care and empowerment. So in our region, there is definitely a shortage of diabetes specialists, no question, shortage of endocrinologists, shortage of nurse educators, and a shortage of mental health professionals who are willing to see people with diabetes. That's huge. It's very hard to find someone. So pre-COVID, we didn't have enough resources. If we could use remote visits and take advantage of expertise in other places in the country to help our patients and help meet our community needs and our regional needs, I really think that is the model for the future. So my hope is that insurers will continue to pay for these remote visits. We can't go back, please. We really don't want to go backwards. So in the future, we can better meet the needs of many more people with diabetes, and in so doing, reduce the morbidity and mortality associated with diabetes and improve their quality of life and the quality of life of their families.
What you're describing there with all the different specialists is something that used to be referred to as the patient-centered medical home. I don't know if you guys remember that, but it was a great concept, but never really got executed on because the logistics of getting people physically to see patients was so difficult. So in this new sort of virtual world, maybe we can see that happening. And it looks like David Pence here wanted to add something to this as well.
There's one bit of technology that's out there that we're going to be using in the second trial that we haven't really discussed, and that's decision making or decision support algorithms that run in the background. And at this point, there's one that's FDA approved for use with a continuous glucose monitor and insulin pumps, DreamEd, which also was a Helmsley grantee years ago. But the goal really is to help Dr. Weinstock and other doctors be much more efficient. So what this algorithm will be able to do in the not too distant future is begin to do exactly what Dr. Weinstock said, which is flag those folks that need to be seen more often. If you're good to go and you're not having craziness going on, you can triage those folks to be seen in 6 months instead of 3 months. And that's really what we're talking about, getting to the personalized medicine that currently doesn't exist beyond just words.
And so the insurers have to stop telling us you have to see everyone, 3 months or 6 months. That doesn't make sense.
That's a perfect key up to throwing a question to Dr. Bean, which is where I was going next, about how payers might like to see diabetes care evolve. And part of that, we also had a question come in about whether your peers in your organization or whether you believe other peers just in the payer sphere really have a good understanding of diabetes at this point.
Well, I'll take that question first. I think we're all learning. And the reason we're all learning is because of the fact that most of us are not ourselves living with diabetes. And so we're sort of speaking to this from the outside in. And I think that the opportunity is to begin to learn more about what the actual experience is, as well as the evidence-based root causes of why people living with diabetes do well or don't do well. So my answer to that is we have much to learn. I think I'm very lucky to work in New York State, where we have a pretty proactive forum of medical directors who we actually meet all plans together to try to look at best practices, and certainly in the Medicaid program, promote best practices as well. I think from what I'm hearing today is really exciting. I think it is going to be how we leverage telemedicine from our perspective going forward. Yes, telemedicine is here to stay. Yes, payers want it. I would say that for post-COVID, which will be with us for a while, I think our vision is that our members continue to have access to these valuable resources that you've talked about. One reason that we partnered with Cecilia Health, is one of the first community-based organizations that we did partner with, is because of access to CDEs. We saw that there were many of our members who couldn't access CDEs, especially through their community. Now, over the years, as Cecilia Health has evolved its thinking and we are with them on this journey, I guess my second part of the vision is to quickly find if members have some life event that has made them more vulnerable. So it could be depression, could be anxiety, could be loss of home, could be loss of job, could be new onset hypertension, whatever it is, because a provider like Cecilia Health is embedded in our network system, they now have access to all of those resources as well. So they don't have to say, Health First, may I refer someone for, this particular social need? They now have access to everything we have access to. So, evolving so that we can actually impact quality of life. And I think if we are able to put in place what you have been talking about with us today, what Dr. Weinstock has said in terms of best practices and both David's, I think that we could actually get to the point that our members don't have to experience complications. They don't have to see their lives fall apart. They are owning their, condition and making it work for them. And then also contributing to the dialogue about what can be best for people living with diabetes. So I think it's reducing the incidence of complications of diabetes, which are devastating to people we serve anyway. And certainly we've seen that with COVID-19, but also making sure that if a life event happens, we're allowing that member or that community resident to have access to the services they need as quickly as possible.
I love that. Thank you. I'm really appreciative of that shift for health plans to be about promoting health and not just being there to pick up the pieces when people experience some, severe health event. So thank you for that. I would love to open it up to questions. And so to the folks out there listening, please enter your questions into the dashboard here under questions. I might kick it off myself with a question. We mentioned a little bit about the fact that there are apps coming out that actually provide like titration advice about, selecting the insulin doses. Obviously, there are tons of apps out there to help people with nutrition and, now increasingly coaching apps. So are you seeing, any of you, an emphasis, is there an uptick in people using those? Are you recommending them more now that we're really going to this sort of, telehealth-based world and not assuming that everyone's going to be able to see a provider face-to-face?
Yeah, David, sure. Please kick it off.
After you, David.
Okay.
Well, on the ground, here's what we're seeing. I mean, there's the 18% of the people who account for 40% of the cost. They need to be brought in with a trusted relationship and everything we've been talking about, the direct relationship with the diabetes educator and with the self-insured employers that we work with. Sometimes there's a dozen people that account for $500,000 of cost, and they're overwhelmed. They're not downloading an app as their path. They need to be educated first and motivated. So apps have a place, just like the apps that come along with the continuous glucose monitors and the decision support algorithms that David Panzer talked about. What we found is it's critical to educate the patients on the why first. Why are you going to use this app? Why is it going to make a difference? Why do you need to take care of your diabetes? Most people don't even understand what an A1C is or a time in range, or as we talked about earlier, how to take their medication. So they're dealing with, fundamentals first. Let's get them to the fundamentals. Let's get them moving, with momentum in a positive trajectory. And then it's a perfect time to start integrating, apps, technology, decision support, continuous glucose monitors, because now they're ready. They're mentally ready to accept it. They're ready to interpret the data. I think there's a misconception, and we talked about at the beginning, that put an app out there and it'll change. We're seeing across all the populations, less than 5% of the people starting there. It's really the reverse. It's starting with the human touch and then keep getting people motivated to use the technology.
I would just add on, I agree with everything David said. Apps are generally for the uber user engaged patient. The large majority of people with diabetes are not that. And, if you're engaging with an app, your chances are you're going to be doing much better. And there's so much noise and so much, I'd say, what people really want is take my data and turn it into, give me something actionable. Most apps don't do that because that crosses the line to being medical advice. And none of the apps are allowed to do that except for those that are FDA approved. And I know Dr. Weinstock can speak to this a whole lot more than I can.
Yeah, so I totally agree with what's been said, and just a word of caution. There are a lot of apps out there that have never been tested, nothing's ever been published, and actually are inaccurate. Not the ones that are FDA approved, of course, that actually recommend insulin titration, but there are a number that have a lot of deficiencies. So if you are going to recommend an app, you really have to do some homework to make sure that it's, I mean, there are thousands of apps out there. I'm not saying that there aren't some that are good. There are some that are, reliable and excellent, but there are some that aren't.
Yeah, another question I might throw at you is about sort of training the next generation of providers. I mean, one of the things we talked about the lack of endocrinologists and how we need more people going into that field. We probably need them to also be trained in a different way. And, traditionally certified diabetes educators, the path to becoming one was, somewhat convoluted and quite burdensome with the amount of hours people had to get and sitting for a test. And, sometimes people were in the position where they couldn't get those hours if they hadn't already passed the exam. So there was this whole kind of conundrum. What would you say about what we need to do there to bring on this, next generation of providers who are ready for this blended care that we've been talking about?
Yeah, so I think that all specialties need to rethink the way they do training, and not just physicians, but also nurse practitioners and PAs and nurses, dietitians. There are many ways that we can improve care, and we could have people who have special interests in diabetes, who are internists or family practice docs. I mean, it doesn't have to be an endocrinologist. I think the most important thing about wanting to help people with diabetes, it really has to be a passion. I mean, and one of the roadblocks at the moment, at least on the physician side, are the reimbursements. So that endocrinologists are certainly in academic institutions are one of the most lowest paid of physicians. And it's based on this RVU system, which doesn't take into account all this, the extra effort that you put in between visits. So it's a very complicated issue, but overall, we definitely need to change the model.
Got it. We have a question here. I'm going to throw this one at Susan. It's about the future of telemedicine reimbursement. I think there's some concern that there's obviously it's very obvious that it's needed right now, so there's a lot of attention on it, but will coverage fall off as time goes on?
You're on mute, Susan.
Yeah, are you on mute? Oh, that's the problem.
At least from the point of view of CMS, and I work in New York State, we have seen over the period of COVID, attention to being sure that people do access telehealth. What we are doing as a payer is concurrent with that is encouraging our physician and other practices to qualify for ongoing telehealth. So, telehealth, to Dr. Weinstock's point, is an investment. It's not just picking up your phone and speaking with a patient. There have to be attention to privacy, confidentiality, et cetera. So, we are going to have to be sure that, we have a contingent of practices that are equipped to do telemedicine. And once that happens, you're right, for the Health First model, we're a value-based model. So, for us, telehealth showed value anyway. And I think that many insurers feel the same way, that this is going to be the way that we serve our clients, whether they're consumers or small businesses or large businesses, better in the future. So I think there's going to be this shift toward telemedicine, this blended reimbursement model. How quickly all of the payers get there sort of depends on who's driving that marketplace.
Great, thank you. It looks like we have pretty much one more question here I'm going to throw at you all, and then we'll wrap up. And that is, someone says, what else can be done to address this behavioral health needs of patients? Here's screening and referral, but we still have the stigma and the inefficient access to specialists.
I'll start. Our vision is to decentralize the knowledge and have the ability to have somebody see a mental health professional virtually. You're seeing all of these companies now popping up where they'll engage you via text, via Zoom, however you want to engage. That is the future of mental health. What I'm lobbying for is to make it front and center in chronic disease, because as I said earlier, there is no health without mental health. And if we keep on trying to put a Band-Aid on the overall problem, we're never going to solve it. So I do think that we need to encourage the payers and show them data. Part of what we're going to do in this study is show them data that compares those who have a mental health intervention in addition to, the rest that Cecilia is going to provide, and show them better outcomes. It really is extremely obvious from my point of view, but yet they do want to see the data. And certainly in primary care, there's tons of data that if you layer in mental health with even primary care, the outcomes are very cost efficient for the payer.
Yeah, I'm going to agree with David and that point of view. I mean, I think what I would add to it is this no wrong door approach. Stigma is a big issue. There are many people who are marginalized in society as well as in the healthcare delivery system, frankly, because of their diabetes, not even solely because of their mental health conditions. So we're really pushing for no wrong door, so that when I am ready for that care, I can receive it. And we're very hopeful that we can also see some data from Cecilia Health, who has been identifying this for us over the years, being able to do some direct referral at the moment that people are ready for that help.
Yeah,
Awesome.
and I would add as well that there's two parts. One is, as David said, there's a lot of apps that are showing up in different technologies. It's critical that the engagement take place in a medically proven protocol. We've spent, again, the last decade developing clinical pathways. Somebody's overwhelmed with their diabetes. How are you going to handle that from an emotional perspective, behavioral perspective, and do it in a safe way? And all those different protocols are critical. And whether they use Cecilia or some other technology, it's a must-have. The other part is paying attention, related to Dr. Bean's point, to social determinants of health. The human part, and looking at food insecurity, making sure that we leverage the resources provided by the payer that might provide even resources to food and food pantries and community resources. And that's critical for us to be able to really take a look, as we've been talking about on this session, the whole patient, and make sure that whatever entry point they have to our ecosystem, that we're delivering the whole value to them.
Okay, thank you, David. It looks like we're at time and we need to wrap up, but I see a lot of questions coming in, and I would encourage the folks out there to keep putting them in, and we will address them after the fact. We're going to be able to post the answers to those questions, so don't be shy about adding your question. But just to wrap up sort of what we heard here today, I think it's very encouraging to hear a much more holistic approach to diabetes care than I think we've ever had before. We've sort of been kind of forced to address that, which I love, and addressing that in a blended model of care, which Susan put so eloquently, blended care forevermore. I love that, and I really think that's definitely the way of the future. And because we're doing these things, it's going to be forcing changes to the business model that are long overdue, I think, and a focus on outcomes that's also long overdue. So I want to thank all of the panelists for being here today, all of you out there for being with us and listening, and of course the Helmsley and Cecilia organizations for the work that they are doing, the great work that they're doing to improve life with diabetes. Thank you all so much.
Thank you.
Thank you.